Arrow International is well known for its high-quality central venous access devices. Our newest device is a peripherally inserted central catheter, or PICC. Many features of Arrow's central venous products are incorporated in the Arrow PICC catheter and procedural tray. To give you a better understanding of the features and benefits available from Arrow, let's look at the contents of a 5 French double-lumen PICC kit. Peeling back the lid stock, you will find several items needed before establishing a sterile field. First, the patient information booklet is available as an adjunct to patient education. A tourniquet and 2 measuring tapes are provided to assist in vein selection, determining catheter insertion depth, and upper arm assessment. The yellow warning sticker on the CSR wrap serves as a reminder to obtain a post-insertion chest X-ray to ensure proper catheter tip placement. Next, you will find antiseptics for preparing the skin, as well as product usage instructions. Entering the interior of the kit, you will find 3 sterile drapes. The large fenestrated drape, designed with an offset opening, provides additional drape length where it is needed to cover the patient's lower arm and hand. The 2 smaller drapes can be used for additional coverage. Dressing supplies include gauze pads, an Opsite 3000 transparent dressing, skin prep, povidone iodine ointment, Steri-Strip closures, and a stat-lock anchoring device. The unique stat-lock anchoring device used with the catheter clamp and catheter box clamp minimizes the potential for catheter migration after insertion. To decrease the risk of needle stick exposures, Arrow User Guard needle-free injection hubs and the Arrow Sharps Away are included. Arrow's PICC catheter is constructed of polyurethane, a flexible material which softens further after insertion. Yet, Arrow's 4 French and 5 French PICC catheters have enough column strength to insert without a guide wire or stylet. The patented BlueFlex tip is a softer form of polyurethane than the body of the catheter, thereby reducing the potential for vessel wall trauma. The proximal lumen of the double lumen PICC is located 1.7 centimeters from the distal lumen. Research has shown that staggered port configuration decreases particulate formation when simultaneously infusing incompatible solutions. The peel-away contamination guard is fitted over the entire catheter length, allowing insertion with the gloved hand and decreasing the concern of causing talc phlebitis. The entire catheter is marked in 5 centimeter increments, with the last 10 centimeters marked individually. This feature allows initial assessment of catheter insertion depth and continuous assessment of catheter movement. The catheter body and the juncture hub are injection molded for improved strength. The juncture hub has integral suture wings for anchoring and a low-profile design for patient comfort and ease of dressing. For easy identification, the extension lines are clear polyurethane marked with lumen position, gauge size, and end in a lower connection. Slide clamps are provided on each extension. The peel-away sheath over introducer needle system eliminates the needle prior to catheter insertion, thus eliminating the potential for catheter shear from an introducer needle. The many benefits of the Arrow PICC catheter are highlighted in the following demonstration. The procedure begins with verification of the physician's order for PICC line placement and follow-up chest X-ray. An initial assessment is made to determine whether the patient is an appropriate candidate for PICC line insertion. Informed consent is then obtained. A baseline upper arm measurement should be recorded on the patient's chart and patient ID stickers to permit subsequent assessment for phlebitis. Begin the procedure with a surgical hand scrub. Place the tourniquet near the axilla to avoid contaminating the sterile field. In adults, PICC catheters are most often inserted in the basilic, median cubital, or cephalic veins. Once the insertion site is selected, the tourniquet is released and left in place under the arm. Using a measuring tape, trace the path of the selected vein. Using your institution's policies, CDC guidelines, and infection control principles, choose an appropriate antiseptic for site preparation. Maximal sterile barrier precautions are advised for PICC line insertions. Before beginning the actual procedure, prepare and arrange all equipment as desired. Topical cream, lidocaine, and saline are 3 possible local anesthetics. When using a trimmable Arrow catheter, retract the placement wire approximately 1 to 1.5 inches further than the point where the catheter is to be cut. Use the sterile trimming device provided and make a straight horizontal cut. Begin the insertion procedure by reapplying the tourniquet, replacing sterile gloves, and performing the venipuncture. When flashback is established, advance the needle and peel away sheath together until the sheath is adequately within the vessel. The tourniquet should be released before the needle is removed. While holding the sheath steady, remove the needle. In order to minimize blood loss, the split finger technique is utilized by this practitioner. In order to gain venous access using the Seldinger access technique, insert the introducer needle into the vein and aspirate to determine venous placement. Insert the spring wire guide through the introducer needle into the vein. Advance the spring wire guide to the desired depth. Hold the spring wire guide in place and remove the introducer needle. Thread the tapered tip of the dilator peel-away sheath assembly over the spring wire guide. Grasping near the skin, advance the assembly with a slight twisting motion to dilate the skin, subcutaneous tissues, and entry point of the vessel. Insertion of additional dilator length increases the risk of vessel damage. Sufficient guide wire length must remain exposed at the hub end of sheath to maintain a firm grip on the guide wire. Advance the peel-away sheath over the dilator into the vessel, again grasping near the skin and using a slight twisting motion. To assess for sheath placement, hold the sheath in place and withdraw the spring wire guide and dilator as a unit to allow venous blood flow. Next, insert the distal end of the catheter through the sheath and begin advancing the catheter. The pre-slit contamination guard will peel away during catheter insertion. When the predetermined length of catheter has been inserted, the sheath is withdrawn and peeled away while holding the catheter securely. If the entire catheter length will be inserted, remember to remove the introducer sheath before inserting the last 2 inches of catheter so that the sheath can be peeled away. If the catheter includes a placement wire,
Remove the placement wire and remove the lower lock sidearm assembly together by pulling straight back. The lower lock sidearm assembly is designed for flushing during catheter insertion and to ease wire removal. The sidearm is not designed for post-insertion infusion. If the catheter and box clamps are needed for catheter securement, they are attached by placing the yellow catheter clamp over the catheter approximately 3/4 to 1 inch from the insertion site. The blue box clamp fits over the yellow catheter clamp to make a snug fit and secure the catheter. Sutures can be used on this anchoring site, or the unique stat lock can be used to make it a suture-free procedure. To utilize the stat lock anchoring device, place it 1/2 to 1 inch below the insertion site with the posts aligned beneath the box clamp. The box clamp is then pushed onto the stat lock. Because of oozing, which often occurs immediately after catheter insertion, a sterile gauze pad is often placed directly over the insertion site and a transparent dressing applied. In many instances, the gauze dressing can be eliminated at the first dressing change. The final step is the post-insertion chest X-ray, which should show the catheter tip in the distal superior vena cava, above the cardiac reflection and parallel to the superior vena cava wall.